as I said, this is our wonderful second in the series that we are presenting. So, as Dr. Mulligan mentioned, just a little bit about this initiative. So, this is a very new initiative from our school, and it really is focused on understanding the evolving healthcare landscape. Our purpose is to educate not only our students who are here, which I'm very happy for, but also our community, and I think there's some community members here as well as healthcare professionals in key areas of health and wellness. Today, we are going to explore the concept of health justice, a vision of a world where everyone has the opportunity to attain their full health potential. Now, this vision is intimately linked to the social determinants of health, the conditions in which people are born, grow, work, live, and age. So these factors include socioeconomic status, education, housing, and environmental exposure. These all significantly impact our health outcomes. Now, for too long, we've seen how systemic inequalities have perpetuated health disparities. We have seen how marginalized communities face disproportionate burdens of chronic disease, mental health conditions, and premature death. So these disparities aren't simply a matter of individual choices or genetics, but rather the result of broad social and economic factors. So how do these factors, called the social determinants of health, influence the ability to achieve health justice? How can we move toward this type of health justice? So this is what we're going to learn about today. This is what our speaker is going to talk to us. So with that, let me go ahead and introduce the speaker. Dr. Julia Ayashura, MD, is the Executive Director of the Dalio Center for Health Justice, where she leads initiatives in addressing health disparities related to race, socioeconomic status, and limited access to care. Since its 2020 founding, the center has partnered with New York Presbyterian Weill Cornell Medicine and Columbia Vagelos College of Physicians and Surgeons to improve health quality and outcomes for diverse populations. So Dr. Ayashura is a native of Southern California. The weather, I'm sure, is much better today, and moved to the East Coast to attend Yale University, where she graduated with a BS in molecular biology with a focus in neuroscience. She joined the Columbia community at Columbia Vagelos College of Physicians and Surgeons and chose to pursue a dual degree with Columbia Business School, graduating with not only an MD, but an MBA. After completing her residency in internal medicine at Columbia, Dr. Ayashura stayed as a chief resident for a year before joining the Division of General Medicine at Columbia. She completed a part-time fellowship, which this is very exciting for me, in medical simulation at the Mary and Michael Jaharis Simulation Center at VP&S during her first year in the division. Now, with over a decade of medical experience, Dr. Ayashura previously served as the Associate Chief Medical Officer for Service Lines and co-director of the Care Team Office. She also directed the LEAD Academy and has been the Associate Designate Institutional Official for Graduate Medical Education at NYP hospitals, along with serving as the Associate Program Director for Columbia Internal Medicine Residency. Oh my gosh, you've just done a lot. So she not only is the Executive Director, she is also Senior Vice President of Health Justice and Equity at New York Presbyterian and is an Assistant Professor of Clinical Medicine at Columbia University Irving Medical Center and continues to provide patient care as an internist in the hospital. Wow, when do you have time to sleep? So please, let's give a warm welcome to Dr. Ayashura.
So hi everyone, thank you for joining us this evening. I hope in the next 45 to 50 minutes or so, I can tell you a little bit about the work that we do, how we centralize our patient's voice in the work, and how we really think about the community connections that are necessary to truly advance health and well-being. At the end, if we have time, I will put a little bit of a plug in for some of the work that we just completed, mainly because I'm really excited about it, and it was a bit of a career high for me. You'll see when I get there. And hopefully someone in the audience will keep me honest about time. I tend to get really excited about this work, and so the next thing I know, 45 minutes is gone. The other thing I will say, if you have a burning question about something that I've been talking about and you can't hold it in, please feel free to just call it out and ask me. The goal of this is educational. It's for me to share in what we work on and share how we think about health justice and equity. And so if you've got questions about that, please feel free to ask. So we're going to talk today a little bit about health justice and why we call it health justice rather than health equity, what the difference is. We'll talk about the social drivers versus the determinants of health. Then we'll talk about what we do at New York Presbyterian. How do we think about SDOH? I will talk about the Dalio Center for Health Justice. That's my, it is in some senses the most career-defining work that I've had. I love what I do. I love the fact that every day I get to come in and think about how we make the healthcare system better. So the first is, why do we say health justice rather than health equity? And I love this pictogram. It sort of tells the story of how we got to health justice. But when we started the Dalio Center 4 years ago now in 2020, most people were using the term health equity. And that is the right term to use most of the time. So when you look at these pictures, you can clearly see what inequality is, and I think we all know what that is. In this case, we have 3 people. We could think of them as patients, community members, your family, your friends, and they're blocked by a fence. On the other side of that fence is your optimal health. We've already heard about the idea that our job is to really think about how we provide care that helps people achieve their optimal health. So inequality is, in this case, that only one person can really see what's on the other side of that fence. Equality would be that we give everyone the same things, regardless of the starting point. And we can still see that now 2 of our 3 patients, community members, family members, can see over the fence to their optimal health, but our 3rd person really still can't see to the other side. Equity is customizing the interventions, understanding that not everyone starts at the same point. And this is something near and dear to what I do as a physician, clinician, bedside doctor. I don't give the same medicines every single time. We customize the care to what the presenting symptoms are. We think about the plan. That's equity. And that's 95, probably 96% of what I do is equity, customizing the tools. Justice comes into play when you ask the question, why is there a fence to begin with? Why do we put up barriers? Why do we have to customize the tools? Couldn't we rethink a world in which everyone starts with the potential for greatness, the potential to achieve whatever their definition of optimal health is? So when we think about justice, we think about breaking down that fence, breaking down the barriers. Those are the systems that are at play. Those are the structures that we try to redefine. And that's why we chose the term health justice. Health equity is core to what we do, and if you see in my title is health justice and equity. We do both. So I'm going to talk for the most part of this around the social determinants of health. And you'll see that I put social drivers / determinants. And I think that's because we're in a bit of an inflection point. We've called them the social determinants of health for quite some time, but many people have started to change the lexicon because determinants implies that these are unwavering and unchangeable, that you are determined to achieve X, Y, or Z, that we cannot redefine that for you. Drivers implies that these create some of the conditions that you're in, but they're modifiable. So you'll hear both terms. We use them interchangeably. I think in the next couple of years, you might see that things are now the social drivers of health rather than the social determinants of health. So in my talk, you'll see a lot of determinants because these are definitions by either the CDC or in this case, the World Health Organization. And we like this definition a lot, that the social determinants of health are the conditions in which people are born, grow, live, work, and age. And I say if we do our jobs right, it's the conditions in which people thrive. And when you think about the structures that create these conditions, for the most part, we think about health factors and health outcomes. I think people would be surprised to understand that only about 20% of what I do as a bedside clinician is what influences your health outcome. 80% of that is the lived conditions in which you bring with you to the healthcare system. So where you're born, how you grow up, your education, your access to healthy food, your access to transportation, and the healthcare system. And what I'm going to talk about today is how each of these individual social drivers impact health outcomes. But first, we're going to go on a little walk. Well, in this case, it's Manhattan, so we're going to take the train. So I used to live on the Upper West Side, and if you look at the Upper West Side, this is life expectancy at birth. This is about an hour and a half on the 3 to go to Brownsville in Brooklyn. Life expectancy at birth has a 10-year differential in these two neighborhoods. That's staggering. I think it's about 3 years for every couple of miles. This is about 9 miles of difference. And so a lot of people have asked over time, what drives this? Why is there a 10-year difference in life expectancy based on neighborhood? And so I will show you a number of things. Median household income, very different. In fact, though, we're seeing a decrease. I updated these slides just a couple of days ago, and median household income in the Upper West Side used to be at $140,000 until pre-2020, and now has become $113,000. There's differences in graduation rates, and we use this as a proxy also for access to the public education system. There's massive differences, and this is what keeps me up at night, massive differences in childhood poverty in these two neighborhoods. And although we would think of most of New York City as severely rent burdened, there is about it's gotten a little bit worse since 2020, but there's about a 10 to sometimes 15% gap in severe rent burden, which means that more than half of your annual income goes to pay your rent. But astute people will ask, you can't just throw up statistics or numbers and say, well, that influences your health outcome. You can't just show me differences in two neighborhoods and then say, well, that's the lived conditions and that will influence how long you live. So a lot of people have studied this, and they've studied it over years. So now I'm going to walk through what some of that background data has shown us over time. The first is in education. This slide only shows that with high school education alone, your odds of death decreases. So that jump that you see in the middle is years of education. And we've also seen that this is consistent also with a bachelor's degree. This is updated data. That last one I think was about 2001. This, you can see that big drop, that was in 2020. So we're seeing the difference in life expectancy. The blue line in this case is people without a bachelor's degree. The brown line on top is people with a bachelor's degree. And the life expectancy in this case at birth is over 10 years different. So education and access to the educational system has true effects on your overall health outcome. Access to the healthcare system is incredibly important. I never discount what we do within the hospital walls, within the healthcare system walls. It's incredibly important. It's why I went to school, to be a doctor. This study showed that there was, it's an old study, so it was 1993, but there's a 25% higher risk of death amongst those that are uninsured. We look at uninsured as a sort of proxy as well for access to the healthcare system. So this is a comparison between those that are uninsured versus private insurance. 25% difference. That's not 25 years, that's 25% difference in your odds of death. This is more recent, so now we're looking at the built environment and where you live and hopefully thrive. This is data from 2020 and 2021, looking at the effects of COVID. So as you go from and I'm reversed here, so I'm probably gonna say left and right when I mean right and left, because I'm looking down. But as you go along the x-axis, let's say that, to increasing quartiles of, this is looking at housing and poor housing, there's not only an increased incidence of COVID, there was an increased risk of death from COVID. So as housing quality decreased, your risk of death from COVID increased. I think that's something that, we saw that in 2020 during COVID. People that lived in congregate housing, people that could not isolate, people that didn't have the ability to move into a different room when their family member or their, roommate had COVID. That increases transmission of what was a highly communicable disease and increased risk overall of mortality. When we look at social and community context, the same holds true. So this is log age-adjusted mortality and life expectancy. They're both showing about the same thing, that we've had a persistent difference in life expectancy between Black Americans and white Americans since the 1900s. This is adjusted for many of the comorbid conditions that you would associate, so cardiovascular disease, cancer, et cetera, and there's still a persistent difference. Many people use some of this research and literature to try to understand what the effects of systemic racism are in our society. And I will call out that the only time that these two graphs match is in 1918 to 1920. For those of you that aren't historians, that don't remember what happened in that time, but that was the Spanish flu. So there was just that in that case, everyone's mortality at that point was, I think, below 30. The last, economic stability. So I showed you some financial numbers that differ between Brownsville and the Upper West Side. And in this case, along the x-axis, it's just you make more money. So as you make more money, you live longer. For those of you in the audience that can see, the top line is women, bottom line is men. At every age, the women live longer. We've known this for quite some time, but finance matters. So these are the social determinants of health. We've had a lot of research to say that they influence your life expectancy. Where you live matters. But I think it's really important to understand that we can influence this. And I'm going to show you a way in which we negatively influence this for quite some time. But this is why policies are so important. This is the map I showed you in the beginning. This is life expectancy as of 2020. Different gradations. Dark blue is you live less. Yellow is you live longer. And these maps, we have them for pretty much every urban city across the country, match really well with some maps that we had from the 1920s to 30s. These are called redlining maps. The Housing Loan Corporation of America surveyed every major city across the country and developed these maps. These maps show where were areas that were considered concerning for investment. So they were redlined. Areas that were green, areas that were blue were considered that there was less risk of losing your money. So those were areas in which there was incentivization, they were incentivized to offer home loans. And with home loans and home ownership came schools, came banks, came hospitals. So in redlined areas today, so today in 2024, in redlined areas from 1920, we see fewer banks, fewer grocery stores, fewer schools, fewer hospitals. This is what leads to some of the changes and the differences in expected mortality and expected life expectancy at birth, because of public policies over a generation ago, so 100 years ago. And this holds true for every major city. So if you want to look at this for Detroit, they exist. If you want to look at this is Manhattan. You can look at this for Brooklyn and many others. But this is what drives a lot of us to say public policy is important. This is why we think about health justice, because we put up barriers. We caused areas of our own cities to be disinvested over time. A colleague of mine that I went to residency with just published a paper I think 2 years ago, looking at redlined areas of New York and controlled for every factor he could think of, every comorbid condition, every known social determinant of health. And yet, people that had lived in redlined areas still had a statistically significantly increased risk of stroke, even controlling for everything. Understanding that there is something about the community context, there's something that we can't necessarily yet quantify about the intersection of schools, housing, free play, green spaces, clean air. Our most recent Dalio Center conference in October was on environmental justice. I'm not going to talk about, that could be a whole nother talk, so I will just put a plug in that we have all of our videos up. And so learning about where do we have refineries, who is actually breathing clean air, these redlining maps come right back. So those are the social determinants of health. I went through them really quickly. I showed you a little bit of data. You can trust me or not that there is a wealth of literature that looks at the social determinants of health and overall health outcomes. But it's why, if I'm a doctor and I care about people's overall health and well-being, I have to think about the social determinants of health. I am one piece of that when I'm at the bedside, an important piece, but just one piece of that if I really want to think about changing some of these health outcomes. So I set the stage of the social determinants of health, but now I want to give a case example in in cardiovascular disease and in health disparities in heart disease. So there have been racial and ethnic disparities in heart disease for quite some time. They are persistent and pervasive. This is from 2019 that shows that the prevalence is more than twice in Black Americans versus Hispanic Americans. There's also some data looking at overall mortality, so age-adjusted mortality. Black adults in the United States are 32% more likely to die from cardiovascular disease. So we've known this data for quite some time. This study goes back to 2008 and now into 2018, but a lot of these are still pervasive today in 2024. And so when we think about the social determinants of health and we think about cardiovascular disease, people have taken those two frameworks and said, well, how do we put them together? So if we see increases or differences or disparities in cardiovascular disease, can I look at that social determinants of health framework, all the things I just told you about, education, housing, food, et cetera, and can I marry the two? So there are a lot of really beautiful, this is where I get excited. These are the things I think are beautiful. Beautiful frameworks around the social determinants of health and cardiovascular disease. So this looks at economic stability and how does that influence psychological stress? How does financial distress influence your risk of, I'll talk about it in a second, allostatic load and increasing your risk of atherosclerotic disease? How does where you live influence the food choices that you're able to make because you either live in a food desert or a food swamp? Those have effects on your overall BMI, rate of obesity, diabetes, and you can play this out in every single one of the social determinants of health. And this is what the newer literature is doing. As we think about cardiovascular disease, as we think about cancer, as we think about stroke, it's what's the interplay of these health disparities with the social determinants of health. But again, I like to show data so that people aren't, she's just talking about these things because she believes in them, but what's the data behind this? So this is heart failure readmissions to a hospital at different income quartiles. So long story short, as you make more money, you come back to the hospital less after you've been discharged with heart failure. You can posit a lot of reasons for why that could be true. Access to medications may be easier. Access to follow-up may be easier. But again, the influence of economics on just coming back to the hospital with heart failure has been evidenced multiple times. This is a little bit hard to see. I didn't know we'd be so far away, so I'll just tell you what this shows. So this was a large cohort from 1987 to 2001, and it looked at fatal and non-fatal cardiac, so fatal MI and then non-fatal MI. Looked at different levels of income and different levels of education. Long story short, more income you have, more education you have, the less likely you are to have a non-fatal or fatal myocardial infarction. This goes back to some of what I've shown you before about the intersection of just economics and financial security on your mortality. But now we see it in heart disease and in heart attack. A colleague of mine who I very much admire, who is the director of the Center for Health Equity at Cornell, Dr. Monica Safford, she studies this. And she actually just studied, this was I think published in 2019, maybe, somewhere around there. She studied whether or not just counting up the number of social determinants that you had was indicative of your overall risk of fatal and non-fatal heart attack. So just counting them. Do you have one risk? Do you have two? Do you have three? Do you have four? And what you can see behind me is that it's a stepwise increase. The more risk that you have, the more insecurity, whether or not it's educational insecurity, financial insecurity, housing insecurity, it's a stepwise increase in your risk of both fatal and non-fatal myocardial infarction. So they are additive, unfortunately additive. This is another way to look at that. It just splits it out, saying, these are survival curves. So do you die more frequently? The answer, again, with increasing numbers of social determinants of health, the risk of death increases. And then the last one, I mentioned this kind of briefly, this is looking at allostatic stress. So this researcher, it's a great study, surveyed patients and asked them about their perceived social stress. So what's your perceived stress scale? Also asked them about financial insecurity. So used a cutoff, I think about 35,000 here. And it's anyone who wants these slides, you're welcome to have them, because I know it's kind of small to see that up there. But this looked at years, so up to 8 years of follow-up, and then just looked at incidence of cardiovascular disease, as well as, again, looking at overall mortality in patients that had perceived stress scales that were elevated. So this idea that there are pervasive things in the community, this is an attempt to look at what the effects of systemic racism may be on stress levels, so it's allostatic stress. Not only was that independently a risk factor, so the more stress that I perceived, the worse I did, but also it's, again, unfortunately additive. So when I had more financial insecurity and I had perceived stress, I died more frequently. The only thing I will add at the very last curve that's interesting is that finances were somewhat protective. So again, the converse of that is true. If someone had a high perceived stress scale, but they didn't have financial insecurity, they did better. So this is an indication that if we can impact the social drivers, these social determinants of health, if we can help people have stable housing, if we can get them better access to good food, they do better over time. A lot of what we do is not rocket science. People need, for those of you that know, Maslow's hierarchy is that you have a roof over your head, food to eat, you feel safe. Those are the things that I care about as a physician. I also do attend in our intermediate care unit, so I see a lot of critical patients. But at the end of the day, what we need to really be focused on is how does that exist in the ecosystem that someone lives? So their study was, I think, 2022, which expanded on some of those prior frameworks. They're extremely complicated, but this is where the academic in me gets really excited because someone's taking the time to draw all of those connections to say, how does all of this fit together? How does all of this work? If we think about systemic stress, if we think about systemic racism, if we think about health disparities, how do those all fit together to lead us to where we are today? The health disparities that we see today, the health inequities that we see today. And what all of this research and literature tells us is that moving upstream as far as we can to prevent much of this is probably the best thing that we can do. We'll never, and this is where I can say as a physician, I will always probably have a job. I will always be able to go into the hospital. We will always have a need for us to be part of the healthcare system, of course. But a lot of our attention should be focused on how do we prevent things from breaking in the first place? Can we prevent diabetes? Can we prevent cardiovascular disease? The literature would suggest, yes, we can. We can do it. And it doesn't take a lot of really complex interventions. A lot of the time it comes back to what I said before, a roof over your head, food to eat, financial security, and feeling safe. Let's throw in a little bit of green space, because that's also really important, getting outside and exercise. But these are not challenging things. They're challenging to bring to an urban environment like New York City. But these are all the things that you could have known when you walked in the door. You didn't need my talk to tell you how important they are. So what do I mean specifically when I talk about moving things upstream? Well, that's starting in the community. That's saying that we as physicians, clinicians, healthcare providers, we're actually at the end. We're there when it's broken. I'm there to fix it when I got to put a Band-Aid on it. But the more that we can build community infrastructure, the more that we can build community resilience, we can prevent many of those things from occurring in the first place. I said when I took the job to run the Dalio Center for Health Justice that my ultimate job is not to have one. My ultimate goal is not to need a SVP for health justice and equity, because we don't have inequities. That's a pipe dream. That's what I think about at night. I'm 44. I don't think that's going to happen in my lifetime, but that's what I should be driving for. That is my ultimate goal, that our communities are so resilient, that we've given them so many resources, that people feel empowered to take care of their own health care, that many of the things that I see today, a lot of the poorly controlled diabetes, the cardiovascular disease, the kidney disease, most of that is a thing of the past. So I hope I've given you an understanding of why we care about the social determinants of health and why it's important for a healthcare system to care about the social determinants of health. We care because I'm not going to be on my moral and ethical sandbox. I'll give you all of the actual regulatory reasons and a lot of the medical reasons we care. But they advance our own goals as an organization. They improve patient outcomes, and they're also becoming regulatory requirements. So Center for Medicaid and Medicare Services recognizes the importance of advancing health equity and health justice and social determinants of health as a key part of advancing health and well-being. We know that managing the diabetes but not thinking about the food that someone is able to get at home, those don't go together. Discharging someone to an unstable housing environment means they're going to come right back. So we have to start to think about really collective and community level care. So I'm going to talk for maybe 10 minutes, 5 minutes, about what we actually do at New York Presbyterian. So how do we address these social determinants of health? And I am the first person to say that we are not the best equipped to do it. The healthcare system is not the best person to address social services at all. But we are a huge convention point. We are everyone comes to the healthcare system at some point, and so we have a responsibility to really collaborate with our community-based organizations to support them both financially, administratively, so that we're all working on this together. And it serves two purposes, right? So if we're partnered with community-based organizations, we're helping to rebuild community infrastructure. That's what we need to build community resilience. So we started a lot of this recent work in standardized social determinants of health screening across our entire healthcare system. We started a lot of that in 2022, but it was built off of about a decade of work that was advanced by Dr. Dodie Meyer at our Columbia campus. She had been thinking about and screening for the social determinants of health for many, many years. And we built off of that a standardized program to screen our patients in the hospital, in our emergency rooms, and in our ambulatory spaces for food, housing, transportation, and utilities. We work with some really wonderful people, both ED navigators who are trained in how to ask the questions appropriately. They're also trained in motivational interviewing, and we've built out significant resources to help them match patients with the needs that they identify. So we have direct service contracts actually with a number of community-based organizations throughout New York City. And if we have a patient that is high risk, meaning that they have a number of social determinants of health that are positive, and they frequently come to our emergency room, we actually do a warm handoff to a community-based organization to address their needs. It looks like this. This is our little schematic for how we work with our community-based organizations. The only reason I put this here is to say that the literature on this and how healthcare systems should be part of it is still being written. And we hope to be part of that because we think it is so important and integral. So we're involved in about a 2-year-long study of this, of really understanding how do healthcare systems and hospitals best address social determinants of health. I didn't want to leave out our community health workers, so I put them in as well. So our community health workers are based in our ambulatory spaces and equally are passionate about providing really dedicated follow-up care to our patients. So that's the social determinants of health, how we think about them, how they embed into a case example, which was heart disease, and what we do at New York Presbyterian. So now I'm going to take a little bit of a broader view, one big step back to say, how does that fit into our entire strategy as an organization? And I'm just going to run through a couple of slides about the New York Presbyterian approach to health justice and equity. And then I'm going to just show some fun stuff about other things that we do in the vein of health justice. This is New York Presbyterian's enterprise strategy. I didn't know I was on Zoom. Okay. Somebody is watching this somewhere. So I put this here so that you recognize that health justice is a foundational element of our strategy at New York Presbyterian. Along with all of our work to provide access, to serve patients, and to advance world-class care, that is embedded on a foundation of health justice and equity. And that's, I think, a really important thing for a healthcare system like ours to say, and to not just have in language, but to also enact. So that's what my role is to help think about how we advance health justice in all of our different departments and divisions across the 50,000 person organization that is NYP. So what that looks like, and I'm not going to go through all of this, is just we have a really detailed and robust infrastructure around health justice at New York Presbyterian. We think about all the different elements and how they fit together, and we think at most about all of the key stakeholders that advance this work. I am one person, and although I'm really passionate and I don't sleep that much, so I can do a lot of these things, I'm not the only person who is equally as passionate about this. We have phenomenal team members across a multitude of departments and divisions who advance the work of health justice at New York Presbyterian. We have a 9-point plan, which I'm not going to go through here because I want to get to some more fun slides, just about how we think about health justice in our culture, in the work that we do for our patients and our communities, and really in the infrastructure that we build. These are all of the people, in addition to our bedside teams, that advance this work day in, day out. But I'm the executive director of the Dalio Center for Health Justice, so I'm going to talk a little bit about what we do in the Dalio Center and how we came to be. So in 2020, I was seeing a lot of patients in the hospital. I actually had moved into the emergency room and saw, I don't know how many patients a day. And during the second wave of COVID, I had a really in-depth conversation with one of our senior leaders who really just asked me how I was doing. And I said, we've just got to do something different. Like, we can't see this again. The health disparities are just so crystal clear. How can we be here? What can we do that's different? And so that spiraled into a number of conversations in which I was incredibly honored to be asked if I wanted to run a Dalio Center for Health Justice. So how could I take a lot of the ideas that I had and put them into action? How could we as an organization do something different? So we bucket our work into 4 key areas: data and infrastructure. And I don't know if there's anyone else in the room that's excited about data as I am. I started as a bedside doctor, never thought I was going to be in data. I spend many, many, many hours looking at spreadsheets. I'm not going to talk about data today. I'll just tell you, we spend a lot of time analyzing our data, looking at patient outcomes, disaggregating data, standardizing how we ask about data. We also do most of our work in clinical and community strategy. That's where our heart is, right? It's our patients, it's our community. But we advance research. Not going to talk about a little bit of research today, but we do support about $1.5 million in research for people across our organization to advance health justice work. And we have a number of fellowships under our belt. There's actually one of my prior fellows, hi, in the audience today, because we want to think about how do we share in our work. So this is a lot of the things we do in clinical and community strategy, but I'm going to highlight just two because they're fun. So the first is when we started the Dalio Center, we picked a number of key areas that we would focus on. One was early childhood and sort of maternal health, and the other was sickle cell disease. A lot of reasons why we focused on sickle cell disease. As a clinician who has taken care of a number of patients with sickle cell anemia over my career, as someone who wrote a thesis paper on sickle cell disease, the prevailing health disparities and the racism that is embedded in the care pathway for many of our patients, it was a passion of mine that we had to address sickle cell care as part of the Dalio Center. And so we built a lot of infrastructure. We worked with our clinical care teams. We have some really wonderful patients who gave us insight. And we said, well, what if we just launch a national campaign for awareness? What would that look like? And it looked like this. So we just closed this campaign actually about a week ago. It started in September, which is Sickle Cell Awareness Month. And it was focused around what you see as a ball, a basketball. We partnered, collaborated with a number of, I'll show you in a second, really wonderful people to advance the message, which was just education, understanding the lived experience of people with sickle cell anemia. The backbone of it was a website, which is still up if you want to take a look at it. It's called sicklecellball.com. And over the 3 months that we had it live, it's 250,000 visits. It went international. All 50 states clicked on it. But what we did was we wanted to say, this is there's about 100,000 Americans that are affected by sickle cell anemia, and a lot of people don't really understand what it is. A lot of people don't understand what the lived experience is, and we just want people to be aware. So we were really fortunate that our basketball, which is a real ball, we made about 2,500 of them. We worked with Wilson. The red part of the ball represents a sickled red blood cell. And we are using this mainly for our patients. So when our patients achieve some goal or milestone in their care, we give them a full size, it's a real size Wilson basketball. But we had really great partners that were really lovely, and they said, well, we'll put a little ball in the game. So this is NBA 2K. For anyone that has NBA 2K25, this is, I think, if you're like level 5, the level 5 prize, you get to play with a little skin of our ball in the game. You can also then click on and learn more, and it takes you to our website to tell you a little bit more about it. Ronnie 2K, who's the ambassador for 2K, posted a whole video about this on his Instagram. It was great. And we did a whole social media pitch. We partnered with a lot of some of these are our patients that posted, some we had ESPN posted and reposted our work. And then this is Ramon Reed. He is Simba on Broadway. He actually has sickle cell anemia. I don't know if this is gonna work or not, but he posted on his website, it might not. So So Jay Snowpro did also post, but we had a number of trick shot specialists who posted, and we ended up with, I think these are slightly outdated slides, about 4 million influencer impressions, I think 350 million impressions overall for our campaign. And the highlight for me was an event that we had for our patients at the New York National Ball Players Association headquarters in Midtown Manhattan. For those of you that are ballers in the audience, you can look really carefully, but in the back is Danny Green and John Starks. We had the most fun, and I got put on, Danny Green put me on his Instagram. We were holding a ball together. We had the best time really collaborating with our patients, showing them that we cared, raising awareness around sickle cell disease. All of these posts are still up. We're probably, and I should get a better post. If you see me in the front, I'm like smiling so hard in the very front of this photo. I'm a terrible basketball player, but I was in awe of Danny Green and John Starks. They're amazing. But this just goes to show you that we do work on transplant care. We look at patient navigation for kidney transplant. We do work in cardiovascular disease. We do a lot of very clinical work in the Dalio Center at New York Presbyterian, thinking about the social determinants of health. We work with community-based organizations, but we also do things like this, where we really want to centralize and focus the voice of our patients and make sure that they feel seen, they feel heard, and that we're all working on this together. We are going to do another event next year because many of our patients were like, we're coming back, you have to have it again. It was so much fun, and it really was. The final post for this event is, so we are the Dalio Center for Health Justice. We were given a $50 million gift by Ray and Barbara Dalio, to start our work, and they have been tremendous supporters ever since. So our final video is Ray Dalio holding the ball, and he passes it on to about 6 NBA coaches, NCAA coaches, the Washington Commanders, I think the defensive line coach, and then to me, which I was like, oh, I get to be thrown in at the very end. But again, the idea of a sort of viral campaign to really raise awareness for what for many was an unknown disease. The other side of the coin is building infrastructure. So we've been working on, and it's still in work, so this is not formalized at all, but for a number of years, our teams in Northern Manhattan have been working on building an early childhood and family hub. They work with phenomenal community-based organizations and partners to think about redesigning a space. So looking at about 15,000 square feet, or somewhere around the 14,000 square feet, and thinking about co-designed, co-located service. So social services, hospital programs, community-based organizations, open play space for kids, early intervention work, music room, food and teaching kitchen. How do we think again about those social determinants of health and bring them all together in a space that prioritizes the family connection? So this is just another project that we support in the Dalio Center and through New York Presbyterian. Lastly, this one's really quick. In education and leadership, I mentioned data, and I said I wasn't going to talk about it because I showed you a bunch of data slides. Research, I just threw that out there that we support a lot of research. Most of our work is in clinical and community, and I showed you kind of the highlights of 2025. But we also try to share as much as we can all of the work that we do. So we just are, I think it's going to launch in March of 2025. We are building a short-form documentary. It's an animated documentary called The History of Racism in Medicine. The goal is to help people understand what some of the history is here, how we got to some of the places that we are in 2025. So we've been working with a design team, and hopefully I'm crossing my fingers that someone, I'm very honored, hopefully says yes to do our voiceover for this. And the goal is to build a 20-minute short-form documentary that is available for healthcare professionals to learn a little bit more about the history. Our ultimate goal is to get this on PBS, so hopefully we'll end up on PBS at some point. But again, it's the idea of sharing our work, sharing the history, making sure that we're all part of the solution. And then lastly, I already mentioned this, but we host an annual conference every year. Our most recent conference was on environmental justice and how we think about advancing health in the climate crisis. I will say, moderating a Q&A with former Secretary John Kerry was both a highlight of my career and also one of the most stressful things I have done as the executive director of the Dalio Center. He was absolutely phenomenal and gave a lot of hope for the future and how we can think about sort of collective action towards mitigating what are sometimes a little bit frightening statistics when we look at the future of climate change. We had about 350 people that joined us in the Brooklyn Museum. We also live telecast this, so I don't know, we usually have a couple hundred people online watching. And we had an artist, a visual artist, sort of live draw all of the themes from the day and then shared this with our the audience at the end. And so that, in a nutshell, this is the little team that makes it all happen. So this is me and the Dalio Center team and our data analysts. So that's how we get from, how do we think about the social determinants of health and the overall kind of impact of the lived conditions that someone brings with them to the healthcare system? How do we think about community resilience and empowering communities to prevent many of the illnesses that we see? And then what do we do about that in our own healthcare system? I threw in a couple of things at the end just because they've been fun, and I was really excited that our social media campaign, which for those of you out there, if you're much younger than I am, I don't have TikTok, I don't do social media, so it was a learning experience for me of how we got like 400,000 views on one of our videos. So thank you very much for your time. I think I'm right at 7, so if there's any questions, I'm happy to take them.
Well, I mean, that was such an amazing talk. I mean, it was just great to hear. I do know what the social determinants of health are. However, I think hearing it from you and putting it into the context, I mean, it's really helpful, and hopefully our students really learned a lot, emphasized. I know they're learning this in class. Let me just ask you a question, because you did talk about it a little bit, but with your background as an MD, physician, so how does the concept of health justice challenge the traditional biomedical model that, you know, all medical students and everybody kind of comes through of healthcare, where the framework is really, the primary focus is on the biological, the physiological aspects of illness, and not necessarily on all of those things that you talked about?
So,
is that not on?
no, it's on. It's on.
Okay.
Thanks. You don't want to hear me anymore. No, okay. So when I went to medical school, we didn't really learn about the social determinants of health. I learned about the social determinants of health, I think, maybe as a resident, and then you start to pick it up as a clinician. You're seeing patients and you discharge someone and you think you have a fantastic plan, you've worked on it together, but you haven't asked the questions about housing insecurity. You don't know what their lived experience is. You don't actually understand, can they afford the 15 medications that I've just prescribed? And so over time, you start to understand, even if you don't learn about the social determinants or social drivers, that these conditions, financial insecurity, housing insecurity, they have absolute impacts on the health outcomes that you see day in, day out. And so I think there's been a shift over time, both an educational shift, so now we have dedicated curricula around the social determinants of health and how they impact the health outcomes that we see. But I think one of the hopefully most important shifts we see is a regulatory one. Mm. So the New York State just last year announced a Medicaid waiver. So it's a way to, it's called the 1115 waiver. I see some nods in the audience, absolutely. It's really long, it's hundreds of pages, so you don't have to read it. I'll summarize it for you. A Medicaid waiver is essentially a mechanism by which the state can provide additional monetary revenue reimbursement for some of the, in this case, social services that are provided. So money to community-based organizations to address food, housing insecurity, some of the things that I talked about in my slides. And I think that's a recognition that what we've been doing for generations is not working. When we look at overall morbidity and mortality in the United States, it's not getting better. Yeah. We see massive divides. We see that, taking out 2020 and 2021, because I think we all understand what happened then, we have an incredible healthcare system that is inaccessible to many people, absolutely inaccessible to many people, is very expensive, and doesn't provide all of the health outcomes that we think it should. And so I think over time, people have started to recognize that the medicine is a piece of it. Mm-hmm. It's a very important piece, but medicine in a vacuum doesn't work. Medicine has to be, and big M medicine, has to be part of the greater construct of where someone lives, how they live, what access do they have, how do they get to and from the healthcare system or not. And building some of those resources and building that community of opportunity actually has far better outcomes than anything I could do as a doctor.
Yeah, I think absolutely, but I think you said it too, and that was going through my mind when you had all of these slides, is sometimes the problems seem just and never ending, and you feel like you're taking these baby steps, but then when you look back and you see. So what would we call success when we talk about achieving health equity? What would you say, that you would feel? You're an expert in this. You run a center.
I do run a center. So I think there's so many different ways to answer that question. I think there's individual successes, so we have specific programs that are, so we support a program in identifying early identification of chronic kidney disease and navigation through to transplant. Because we know that there are significant racial and ethnic disparities in kidney transplantation rates across the country. So the program that we supported increased kidney transplants, increased and sort of changed the demographics, increased access to it through patient navigation, through earlier identification, and a warm handoff so that people can navigate what's a really complicated healthcare system. So that's success to me, because that was customizing the interventions that someone needed to be able to get ultimately what will absolutely change their life. Transplanting patients off of dialysis, that's success to me. Making sure that we have food programs that are sustainable, making sure that New York thinks about sustainable and low-income housing, that's success. But I think one of the reasons why I always show, even though many people see them all the time, I show, and I always will bring up the redlining maps, is because people need to understand how public policy, in this case, where you should give a home loan, had so many other downstream effects that built infrastructure over decades. And that's led to many of the health outcomes that we see. So although it feels impossible, it's actually not. A lot of the answers and the solutions are there. We just have to want to implement them. So success to me, there's a lot of, there's some literature around purpose-built communities, creating communities of opportunity. And I think that ultimately is what success is. It's building resilient communities that have all of the resources that they need. It's not seeing rent burden rates that we see. It's not seeing differences in access to the educational system. That's truly equity.
Seeing those redlining maps, that also puts into perspective how long these issues have been there. And so that's why it's even a harder hill to climb.
Right, but my team, I adore the people I work with. Sometimes, I'll be honest, sometimes it's a little disheartening. Yeah. You see the same statistics over time, and part of what we always have to remind ourselves is that we didn't get here in 6 months. Okay. So my plan, my program, which is 6 months long, is not going to change the world. It didn't take 6 months to get here. It didn't take 10 years to get here. And I'm not saying that we should wait a generation or wait a century before we expect to see changes. Many of the things can be changed in a year or 2 or 3. But it's just a recognition that it's slow, steady progress. It's making sure that we're really thinking about policy. It's making sure that we're thinking about community participation and engagement, that everyone's got a voice in this work. That's where we're ultimately going to see success. But we didn't get here in 6 months. Right. So when people are like, well, but you didn't show me an outcome after 3 months, I'm like, we're not going to. It's impossible.
Absolutely. Okay, I'm going to look out. I got to take off my glasses to see you people. But anyway, any questions from the audience? Yeah, come up here, Macon. Dr. Conti, I should say. Okay.
Is this on? I'm very loud, so I'm trying not to So thank you for your presentation and all the work that you're doing. It's truly incredible and inspiring. You started touching on it, and I just would love to hear a little bit more about how your work is leading to direct maybe policy advocacy. You started talking about on the New York State level, but there's so many other opportunities and just housing equity and all those things. So how are those tied, and how is this incredible data that you're collecting and generating helping in those efforts?
So one of the biggest studies that we were talking earlier about how I was up at our New York Presbyterian Westchester campus, because that's a big part of some of this work in social determinants of health screening and referral. The literature around what healthcare systems should do, how they should best play a role in screening, how they should best refer is completely varied. There's no standardization in how people are screening and referring for social needs that are identified. And when we talk about social determinants of health, I sort of, rattle them off. I talk about it all the time, but these are really, if you're asking someone, these are personal questions. They are, in many cases, sensitive questions. And so when we ask our patients about, food insecurity and then don't have resources to give them, or it's not part of our plan to provide resources, or we can't, we lose a little bit of trust in our patients. And so our work has always said, if we're going to ask the questions, we're going to do our best to have resources. But that's a privilege that we can do that because we're funded to be able to do that. Many healthcare systems can't. So part of what we think is our responsibility, because we do have the funding to do this, is to say, let's study it. Let's understand where's the best place for us to put resources around social determinants of health. And if it's not the best in the hospital, who in the community is the best to fund to be able to do this? We have no ego in it. If it means that we're not the best person to provide those resources, great. Let's fund the people that are the best resources to do that. So the study that we're most engaged in right now is hopefully going to provide a lot of information about the best way that healthcare systems like ours, should engage not only with the screening, because that's now mandated by CMS, but with the referral part of it. And if we're trying to finish our study before the end of the 1115 waiver, which is a 3-year-long waiver looking at community-based organization, social service provision, and funding to CBOs. We're trying our best to get it done in time, because I'm hopeful that what it will ultimately show is that the healthcare system is a great repository for data. We should be funding much of this work, but we're not the best people to then connect patients to the resources. And so we've got to be funding our community-based organizations to do that work really well. We've got to have great data streams back and forth, but that's how we best work together and how we create a network. So that's in social determinants of health. It's where I spend a lot of my time. But in other places, so some of the research that we fund, we did a lot of work in our first couple of years in chronic kidney disease. So we're funding a research study looking at how we can better identify patients at risk of developing chronic kidney disease, how we can better connect them to resources, how we can get them off of wait lists for transplant. And all of that is done with a sort of byline that you have to publish all of this. So I think where we're really trying to move the needle, some of that is in policy around SDOH, and then some of that is in sharing with others through publication and through supportive research. Housing is an interesting one. New York is, we were at a symposium, the whole day was all about housing, particularly in New York. I look to what some of our colleagues are doing in this space. So wonderful clinician, physician in BMC out in Boston, Dr. Sandel has been doing some fantastic work in supportive housing and in healthcare systems funding low-income housing. Also, Kaiser out in California has been doing similar work in this space. And so it's on my 2020, those from NYP, don't tell anyone I said this, but it's on my 2025 list to think about what does that look like for us? Like, New York is a bit different when we think about housing, but we still need to have a voice.
Thank you. Of course. Other questions? Don't be shy. There's mics on.
I'm a senior in the social work program, and my practicum placement is at an inpatient psychiatric unit. So during our assessments, one of the first things we do is look at the social determinants and axis 4 stressors. And in our assessments, we also look at their housing needs and what interventions need to be done to meet all of these needs. And something, as soon as a patient is admitted, we're already thinking about discharge, not just about their mental health or substance abuse or co-occurring issues, but we also look at all the social determinants as you mentioned. So I'm wondering how I was hoping you could provide insight into how effective the interprofessional team is in addressing all of these issues. Because on a routine basis, we are submitting SPOAs, which is single point of access, and we're submitting all of these different types. We're looking at ACT-T, which we're thinking about discharge, and we're thinking about the life that comes after this hospitalization. So I'm just wondering how
Absolutely.
the professional team influences that during the hospitalization.
So they don't influence it, they drive all of it. So I didn't have time to talk about it, but we had 2 annual goals, one from 2023 and one from 2024, all about inpatient social determinants of health screening and referral. The key owners of that with us were our social workers and care coordinators. And we met, I think, every 2 weeks for almost 2 years now, building out standardized pathways to both collect social determinants of health and have it in our EHR, visible in, that's the slide I cut out. Yeah. Just for proprietary reasons, I'm not supposed to share like screenshots of our EHR, but I did have one in there that shared what our social workers are inputting and how we can visualize that in our EHR. And then we have been working with a third-party vendor to build out resources that are visible in Epic, which is our electronic health record, so that we can make in EHR referrals to some of the community-based organizations that I've been talking about. The beauty of that in putting it through Epic is that it's been taking a lot of time, but we worked on it. When the community-based organizations actually see our patients, they can put some of their work back into the same EHR, and we can see it on the other end. But our social work teams and our care coordinators are 110% the backbone of the work that we do in our hospitals around social determinants of health. When we first, so we were one of the first healthcare systems to be certified by the Joint Commission for Health Equity. And when we were going on our tour to talk to people about it, and I was talking to our social work teams, and I was like, well, this is about SDOH, and we started going through this. And I've known many of our social workers my entire career, and there was one in particular, her name's May, and May looked at me and I said, okay, May, so you taught me about this when I was an intern. All I'm saying is that these are the questions they're gonna ask. So, and she's like, Julia, we do this every day. This is why we became social workers. This is what we think about. The social determinants of health are our bread and butter. And she couldn't be more right. So our annual goals, we knocked out of the park because we had such phenomenally dedicated social workers and care coordinators. We need more of you. So I don't know what everyone else is interested in the audience, but we definitely need more social workers. So they are critical to the work that we do.
I'm just going to build off her question a little bit because she said interprofessional, collaborative workforce and all of those things. And we're really trying to do that here. We're trying to, teach about what interprofessional collaborative practice looks like. And so can you talk about that? Like who would be involved? So I'll just tell you some of our programs that are represented, right? So you've heard about social work. We have OT. We have marriage and family therapy, we have health and wellness, mental health counseling. So we've got a lot of folks, did I say OT? So we have a lot of those folks here, nursing, sorry. There's so many, I can't. So how do they all work together in this?
So we have, and I was actually just on service about a month or two, maybe September, time flies. We have interdisciplinary care team rounds every day, and that's where we discuss not only the medical aspects of a patient, but all of the social aspects. We think about the discharge planning, we think about the barriers to care, and we all collectively think about how to solve whatever problem we come up with. And so those are doctors, PAs, nurse practitioners, social workers, care managers. It's our OT and PT because you can't discharge someone who's not ready to go home, who can't ambulate. And in fact, I've been at the same institution for a really long time, so every time I'm talking about someone, I'm remembering how someone has saved me from something where I've called in one of our physical therapists to really help me think about what's the best plan. But I think ultimately it is a multidisciplinary team. It's our respiratory therapists when we're thinking about our patients who have high oxygen needs and how do we get them home safely. It's our occupational therapists when we have someone who's post-stroke and needs to really think about, how can they, how not only it's ambulation, but how can they actually, what's their hand grip? Are they safe to go home? Can they open their medication? So, when we think about, we kind of lump up social determinants of health into like these big factors. If you actually look at the literature around it, it's like 1,000 different things that are all in the social context of someone's life. And I think if you think about it in those terms, all of the different key stakeholders that advance any piece of that are integral to the care team. So we have, just in the hospital, the way it generally works is we have interdisciplinary rounds twice a day. Yeah. And it's nursing, it's physicians, it's the OT, it's PT, it's RT, it's everyone, it's our social workers, our care coordinators, thinking about the best plan of care. Right. For anyone that ever got into medicine thinking it's a solo sport, you got to get out. It is teamwork every day. Yeah. It's how you best work together as a team to think about advancing patient care.
Yeah, that's great. There's a question there. Yeah.
Often in the hospital, we talk a lot about access and events programs and things like that, and we provide the patient with everything. However, there's still balancing. Yep. So where do you see culture, values that have been passed on from generation to generation built into this, and how can healthcare influence that? Because we can give you everything, but if your inner core doesn't believe
So I was actually just at an event earlier this week where we were talking about, well, what if what I think someone needs is not what they think they need? How do we bridge that gap? You know, honestly, there's not an easy answer to that, other than a lot of that takes time to build trust and to understand what someone's perspective, why, what are their cultural beliefs and norms, how they, you know, why is what I think is the best for you isn't what you think is the best for you. And then also taking a step back, it's, you know, ultimately this is collaboration. I have an idea about what your medication regimen should be, but that's got to fit into your life. That's got to be something that you also agree with and adhere to. And so part of the work is in those link there, and we always need more time in medicine because a lot of it is conversations with patients and communities around what are their beliefs, what is your priority, what do I think is a priority, and how do we kind of build that together? But there's, when I talked to a group about 2 days ago, and so it's a lot of time. It's time and conversation. And ultimately what we do is one human talking to another human, and we're gonna work it out together. But it's the story that I was telling someone was that we had very different beliefs on vaccination. And during 2021, I think I gave 150 talks on vaccines. My husband laughs because he heard me on Zoom so that he can actually give the talk for me. He's like, you're gonna talk about mRNA, and then you're gonna talk about this. He's in finance, so it was hilarious. Like, don't give that talk, it doesn't sound good coming from you. But I told this story that I went to a community and gave a talk, and everyone in the audience was pretty much like, we're not gonna get vaccinated. And I said, I'm not here to convince you. I'm just here to give you information, and I'm here to answer whatever questions you have. And if you need me to come back, I'll come back. And if you need me to come back again, I'll come back. And after the second time, a lot of questions again in the audience, hours of a conversation. Everyone actually at the end got vaccinated, and they became a vaccine hub in the future. But there was no magic. It was me understanding what their concerns were and really kind of owning that medicine and this idea of medicine, we don't have all the answers. And that some people prioritize things for themselves that really are their priorities, and we need to understand that and work together. But it's time and a conversation.
And I think it also helps if we can kind of diversify our workforce. So I
Always
think,
helps.
Yeah, it does, definitely. There was another question, yeah.
So one thing that I used to teach a lot. I taught medical students for a lot of years. And one thing I've always just asked people is just, if you're in patient care, just ask your patient. Like if you're in direct patient care and you're discharging someone home and you know nothing about their life at home, you don't know. And for OT and PT, I think it's a little bit different because you do assessments around what's the home environment going to be and how are you best going to integrate back into that in a way that's sustainable. So I think you're already at an advantage there because you are thinking about life outside of the hospital. But what I've always asked people to do is just ask that one more question of yourself of why is this person, and for us it was, why is this person at age X, Y, or Z? Why do they have kidney disease? Let's just think about that. What happened that someone at this age has hypertensive kidney disease? And I want people to just start to think about the social determinants that were in play, some of the access to care issues. And so it wasn't anything that our team had to do, but I just wanted them to be aware of the fact that the system failed this patient, the system failed someone. And how could we think about that for our next patient? Maybe it was connecting that person earlier to outpatient access. So a lot of it is around awareness, because you're not going to be able to create a community of opportunity. I can't do that. I would love to. But a lot of what our work is at the bedside. But having that more expansive view of what someone brings with them to the healthcare system, I think that's what all of us can do. It's just that second check of, why is this happening for this person, and is there something outside the hospital that I could influence that would make it better for them?
Any other questions? Yeah.
Absolutely. Yep. Agreed. There's actually a lot of literature. I showed that one slide about allostatic stress, but if you read the article about that, there's a whole, like, I think 2 or 3 paragraphs about the influence of your sort of nuclear family as well as your community on decreasing perceived stress, and how that's a buffer to people at lower economic statuses. So that's why I kind of zipped through it, but I showed a slide on building an early childhood and family hub. It's thinking about what are the resources that we can provide to give space and time for families. And family is, for me, a very open, like, your family is how you define your family. And so I think when we think about inpatient medicine or even ambulatory medicine, a lot of that work is bringing the family unit together to think about the health care that we're providing. But I think truly when we're thinking about equity and justice, it is in some of this work around like a family hub or a family center that brings community together, and community at the sort of family level. It's providing resources to those individuals. But one thing, and I try not to talk about it too much, because if it doesn't work, then I don't want it out there. But part of what we're trying to study in the work we're doing around social determinants of health is, how does that impact the family unit? So if we provide food services to one person in the family, that's not just for that one person, that's for the family unit. If we think about, housing vouchers, or we think that's for the family. And so part of our dream is to expand one step further to understand that influence of the family and that influence of the community. That's the dream in public health research. So whenever I talk about it, I stop at the individual, but that's exactly where we want to go.
Oh, yeah.
So I love that all of you came to listen to me talk, but I recognize that majority of people are not going to. And I also recognize that most of medicine is not within the hospital. Some of it is in our ambulatory spaces and an outpatient, but most of medicine is actually in your community. It's the friends that you talk to. It's the people, your trusted community leaders that actually influence more how you are going to access and sort of inhabit the healthcare system than I will. I'm not the trusted messenger in a community. I am in some, because I showed up a lot, but not in many of them. So the Dalio Center is just one piece of some of the work that we do. So I'm going to talk about some other really phenomenal work that happens at New York Presbyterian that is doing just that. It's thinking about how do we get as far into the community as we can. And one of the programs, I'm going to stay on the sort of cardiovascular disease because that's what I shared today, is a program called Heart Smarts. And it started out in Brooklyn and Queens, but it's leveraging faith-based leaders, teaching, training. It's like a train the trainer model of you learn about cardiovascular risk, you learn about healthy eating and healthy diet, you learn over, I think it's like a 6 to 7 week course, and then you go on to teach and train others. And that's through faith-based organizations. That's now, I think, hundreds of people have taken part in this education and training. And that's leveraging community leaders to be ambassadors about healthcare. It's Dr. Osborne at our Cornell campus who's doing work in prostate cancer and prostate cancer screening, and that's through going to faith-based organizations as well as to barbershops to get to people, to talk to them about their risks. So I think we've got to break down this idea that healthcare is over there and that you got to go to a brick and mortar in order to get it. We've got to empower people to understand their health conditions and understand their risks. And that looks very different now, as it should. It looks like faith-based leaders, it's community leaders, it's educators, it's your friends and your family. Unfortunately, it's also ChatGPT. I just learned this today, that a lot of people are getting their medical recommendations from ChatGPT, which I find that a little terrifying. But the face of sort of democratizing healthcare has to change. And so it is getting ahead of it by being in the community, by really being rooted in the community. And one thing that I've been so in awe of for the years that I've worked with New York Presbyterian is our Division of Community and Population Health has hundreds of community programs. They work with thousands of community-based organizations. They're in the community with them. They are providing education and resources and helping people understand heart disease, stroke, all of these things. And it's through those mechanisms that we ultimately can provide preventative medicine rather than reactive medicine. But thank you for your comment.
So I'm just going to reference back. So you mentioned ChatGPT, and so I did have one of these. I had a question on here about artificial intelligence, and AI is pretty big. In fact, our last talk, and Dr. Bisi, a friend, so she told me. So we talked a lot about how AI is being used in healthcare. So one of the question I had for you is just about all of this data that you're collecting. Are you using AI?
So everyone is.
Is it helping you?
So as you know, if you were here with Dr. Bisi, who is actually a very good friend, she's brilliant. We are using AI, and we are using AI, but in very specific test cases. And we use AI in sandboxes. So we don't let it loose in our EHR and do all sorts of things. No, it's over here, and it's thought of in the same way that we think of any other research tool. It has to be studied. We have to understand the risks. We have to understand the outcomes. You can't just start a new medication Why would we think we can just deploy a new AI tool without that same level of research? So Dr. Bisi has been working on some phenomenal test cases of AI that actually mitigate disparities, that reduce inequities, because they take the bias out of the system. But that's when it's done really responsibly. And I'm on the Health Equity and AI Committee with Dr. Bisi, so we review all of the AI tools that we're thinking about, and I've been so impressed with their data. Done without that level of oversight, there are healthy concerns that it can run amok. I don't know if any of you have I shouldn't admit to this, but sometimes when I have a free moment, I try to see if I can get ChatGPT to hallucinate. It's not hard. You can get there real fast. You ask it something and you're like, tell me more. Ooh, tell me more about that. Next thing you know, it fabricates a whole history about something. And my favorite question to ask, I challenge you all to do this when you get home. Ask it to give you the resources. Cite it. If you say, can you give me the citations for what you just said? My favorite line from ChatGPT-4 was, well, I do not have actual citations. However, I have inferred based on prior data. That's terrifying. Most people also don't know that ChatGPT only goes back to 2020. So anything before that is not in its lexicon. But the idea that AI could solve some of these problems is absolutely true. AI is going to transform medicine. Hands down, it will, whether we want it to or not. And so if we are truly sort of the stewards of the future of healthcare, then we will be thinking about how AI can make healthcare better, and we will adapt to it and adopt it early. The worst that we could do is just hope that it doesn't cause problems and just like put it over there. That's actually the worst that we can do. So I have high hopes for AI, but I do challenge you to see if you can get ChatGPT to hallucinate, or sometimes it's a little too familiar with me. Like, we're not friends. You're so, but that's what I do in my free time.
Well, I mean, I brought up AI just because you said ChatGPT, but I will say the other kind of fear, right, people have about AI is, oh my God, it's going to come, it's going to take away all our jobs. And I think today, after listening to you and kind of how can we, reduce those health disparities to achieve health justice, you need people. So it's not done by AI, and it's people. So all of you out here pursuing these careers in healthcare and, associated disciplines, you're going to have a job, and it's not going to go away. So anyway.
So they've done some research on that, and no one believes that AI is going to replace the clinician, the physician, the healthcare worker. AI-enabled healthcare workers will replace healthcare workers. So those that don't adopt new technology and want to just kind of stay in their current lane, that's probably not going to last for too long. It's probably decades, but AI-enabled healthcare providers are certainly the future. In our work and what we've seen in our own healthcare system is there's not a single job that has gone away because of AI. It's only enhanced it. The myth of all of this so far is that the goal is that using these technologies and bringing in AI gets people back to the bedside. So takes away all the kind of documentation and the prior authorizations and the faxing and the things that don't really add value to the bedside clinical experience. Unfortunately, that hasn't happened just yet, but I think that's what the next hope is that all of these analytical tools will make us smarter, will make us faster, but will get us back to what we wanted to do, which was that human-to-human interaction.
On that wonderful note, thank you very much. I think let's all give a round of applause.